Thank you very much. Excellencies, all protocol observed. That's what we've learned this morning. Every time I get asked a question, how did Malawi do it? Or how is Malawi doing it? And I give them the simple answer, teamwork. So I hope, Madam Chair, you give me a minute at the end of my 12 minutes to just allow the Malawi team to stand up wherever they are. So this is the just outline of my presentation. I'll talk about the current situation. Also move on to the trends on neonatal mortality. And then moving to scale, I'll talk about the progress, look at opportunities, and finally I'll go through the challenges. So except for the population, the rest of the figures are from the Demographic Health Survey, which we conducted in 2010. Our population is 15.3 million. Country is made up of 28 districts, and our maternal mortality ratio is unacceptably high, is at 675 according to DHS, but according to the UN estimates of last year, we are now at 460. That's still unacceptably high. The neonatal mortality rate is at 31, and globally, we have the highest premature birth rate, which is at 18%. The contraceptive prevalence rate is 42%. Unfortunately, the total fertility rate is 5.7. You might argue why the mismatch there. I mean, this is because I think previously our policies were targeting those who already have families, but now we've changed the approach to include adolescents. We need to catch them before they start having families. I now need to share with you some of our achievements there. As you can see, Malawi is on track to meeting MDG 4 for child survival. But as you can see, unfortunately, the neonatal mortality is going down at a slower rate than the under 5. And this goes into a little more detail on the neonatal mortality trends. I mean, starting from 1990, there are a number of estimates there. But from this, you can see that though it's slow compared to the earlier graph I showed you, but we're doing better than the regional average of 1.5. We are at 3.5. So what are the main causes of mortality among these newborns in Malawi? Our picture is not different from the rest of the world. 3 causes account for close to 90% of all newborn deaths. And here we're talking about severe infections, intrapartum complications, complications related to preterm birth. And under the severe infections here, we're talking mainly pneumonia, sepsis, and meningitis. And all these are preventable. So here, I'm just trying to share with you the trends in coverage of newborn-related interventions and packages starting 2000 to 2010. And as you can see, there's been an increase in the coverages of all key newborn-related interventions, except, of course, the postnatal care, where we haven't done well. And then I'll share with you, because the emphasis now is how do we move to scale on some of these interventions. I'm pleased to report that our Reproductive Health Directorate has played a key role in strengthening the coordination and collaboration of all partners in newborn health programs in Malawi. This actually is to leverage the impact. And then the other thing we've done is to incorporate all the high impact interventions in national maternal and newborn health strategies. Here we're talking about the sexual and reproductive health strategy. We're also talking about the roadmap to accelerate reduction in maternal and newborn mortality. We've also harmonized the integrated maternal, newborn, and child health training manual to bring together early newborn care, kangaroo mother care, and also helping babies breathe. And of course, there's also the community-based maternal and newborn care, and of course, complemented with community mobilization. We all know that in-service training is very expensive, and I'm pleased to report here that we've incorporated these high-impact interventions in the pre-service curriculum. And we also promote community, family, and male involvement. Nothing is complete without involving everybody around the table, and male championship or male involvement is also key to our scaling up. We've also integrated community case management with community newborn sepsis, and recently we've been engaged in introducing antenatal waiting homes. What are some of these high impacts? What are some of these high impact interventions that we've implemented at national level? There is the focused antenatal care, the skilled birth attendants, also emergency obstetric and newborn care, helping babies breathe. We've also looked at essential newborn care, KMC, the video you've already seen here, and also community-based maternal and newborn care. The other intervention that, high-impact intervention that we take into scale is prevention of mother-to-child transmission of HIV. And some of you may have heard about the option B+, where we're putting every pregnant woman on ART and also those that are breastfeeding. There are some interventions that are underway. We are still discussing introducing corticosteroids for the lung maturity in the or women going to premature labor. We also are planning on scaling up community newborn sepsis, and of course, continuous positive airways pressure, CPAP. So I'll quickly go through some of the interventions that we put into scale. The first is Helping Babies Breathe initiative. This we launched in 13 districts, thanks to the American Academy and Professor Little, who was part of the Malawi team, that introduced it to Malawi. So now we scaled it up to 21 districts out of the 28, and we've trained over 1,173 health workers. The aim is to improve all aspects of care around the time of delivery, especially the neonatal resuscitation practices. The other is kangaroo mother care, and this was introduced first in the late 90s, but maybe we're not as enthusiastic that time, but we had to rebrand it and bring it out again in 2002. And at present, I can proudly say that we have about 121 units in both government, mainly in government, and also the Christian Health Association of Malawi. And I'm pleased to report that the content of this has been incorporated in the integrated manual as well. And I'm also pleased to report that quite a number of our neighboring countries are coming to Malawi to learn about kangaroo mother care, so we are excited. I'll not be fair if I don't talk about the community-based maternal and newborn care package, which is bringing the care closer to the people. We have a cadre in Malawi called Health Surveillance Assistants, and these are trained, equipped, and supervised. I mean, to visit women 3 times during the pregnancy, to counsel them on the importance of attending ANC, birth preparation, and the various issues around delivery, including the need to come to hospital or to be attended to by a skilled attendant during delivery, and also the postnatal visit. And then they also mobilize communities of maternal and newborn health, and they also strengthen our data collection in the villages. And at present, we've actually gone on to 28 of Malawi districts implementing the standard community-based package. What are the key messages? So I got them all listed out there. It's a combination of efforts that contributed to Malawi's progress. And the convening mechanism played a key role in building this consensus. I'm talking about here the coordination at central level, and we have the Section Reproductive Health Technical Working Group and the Safe Motherhood Subcommittee. And the other is harmonization of these training manuals that we're using for training. The other is community mobilization, improvements in newborn care, and finally, the major one is the task shifting. So despite the few health workers we have, the task shifting has helped us cover some ground, especially with supported supervision and mentorship. There are also future opportunities. There is high-level policymakers' attention to address preterm birth, and we've had a few meetings around that. And we also have political will at highest level. There's a presidential initiative on maternal health and safe motherhood, which promotes an interdisciplinary approach, capitalizing on local traditional leaders. And also, we're planning to include the inclusion of the newborn healthcare indicators into the health management information system. And finally, the Health Everyone campaign, which was launched 2010, which is providing ongoing advocacy. I can't leave without talking about the challenges. The main challenge is, of course, human resource, especially which affects the supervision. There's also an issue of data management and use. I mean, all this information collected needs to be managed properly and also used. There's issues around sustainability and issues around conflicting priorities. And finally, resource for maternal and newborn health is actually inadequate. And on the conflicting priorities, I'll give you an example of a situation where recently we had some maize going bad in our maize silos, and some of the monies meant for health were used to make sure we have extra food. But we know that nutrition is also good for health. So we didn't care that much, but we need to be aware that there are competing priorities in health. As I'd ask you, Madam Chair, it's all teamwork. So I'd like members of the Malawi team, wherever you are, to please stand up so that the gathering here sees you. Just for a minute. So the team comprises government, academia, development partners, local and international NGOs. And I would have been even more pleased if I saw Liz Nelson standing up, Joy Lawrence standing up, Stella Bauer standing up, DeGraff Johnson, Joseph standing up, Steve Wall, Prof. Little, and if they were here, the co-chairs of the Bill and Melinda Gates Foundation, because they've been part of this whole process. Thanks very much.